Welcome to the Deep Dive. This is where we really plunge into complex challenges and try to pull out the most actionable, well, the most eye-opening nuggets of knowledge for you.
Exactly.
Today, we're navigating the pretty high-stakes world of healthcare decisions. We're drawing insights directly from a really fascinating set of clinical practice scenarios from July 28, 2025.
Right.
Our mission here isn't just to give you answers, but really to unpack the crucial why behind critical interventions. The idea is to help you quickly understand the logic, in those fast-paced clinical environments.
Like give it a shortcut, maybe, to truly inform decision-making, especially when, the clock's ticking.
Yeah, a shortcut to understanding. So we're going to try and transform these specific scenarios, these moments of critical decision-making, into clear, actionable understanding for you.
We'll explore the subtle cues, maybe the hidden priorities, and sometimes the ethical tightropes that nurses walk every single day. It's really about building a deeper appreciation for the complex thinking involved.
Okay, let's dive in. Maybe we should start with what are often the most urgent situations. Immediate interventions and priorities in mental health crises.
Great place to start.
Okay, imagine this. A female client arrives for her outpatient therapy appointment, and it's pretty clear to everyone, including her spouse, that she's intoxicated.
Okay.
Her spouse even tells the nurse, we couldn't stop her drinking. Now, our first instinct might be to jump right into the underlying issues, right? But what's the insight here? Why can't therapy proceed?
That's a great point, and it hits on a common misconception.
Right.
While the goal is eventually to address things like alcohol dependence, the immediate insight is about protecting the therapy itself, the integrity of it.
Oh.
A therapeutic and definitely a confrontational meeting just can't happen effectively when someone's judgment is so altered by alcohol. Their ability to reflect, to engage genuinely, it's just not there.
So it wouldn't work.
Exactly. So the immediate action is to tell the client, gently but firmly, that therapy can't happen while she's intoxicated. Then you address the immediate safety and support needs, trying to push through. It's not just ineffective, it could actually damage the trust.
That makes a lot of sense, protecting the therapeutic space.
Yeah.
Okay, let's shift to maybe an even more acute situation. A client undergoing detox for alcohol and multiple substances.
Okay, yeah. Intense.
And they're deteriorating fast. Increased anxiety, agitation, sweating, sensory perceptual disturbances, clouded sensorium. It sounds terrifying for the client.
It is very.
What's the absolute #1 priority intervention here, and why?
This situation screens physical and psychological safety risk. When someone's got symptoms that severe during detox, especially the sensory disturbances and the clouded thinking, they're disoriented, they're highly vulnerable.
Right.
The absolute priority, one-on-one supervision, constant. And this isn't just watching them.
It's more than monitoring.
Oh, definitely. It's critical for ensuring their physical safety until they can be adequately sedated, preventing falls, preventing self-harm. And just as importantly, reducing those feelings of terror, maybe the visual hallucinations they might be having. It's about containing the chaos, providing immediate, constant reassurance.
Containment, reassurance, safety. Okay. And building on that, during alcohol withdrawal, you mentioned self-destructive or violent behavior is a real risk.
Absolutely. Extreme agitation, hallucinations. It's a volatile mix.
So what's often the first practical step a nurse needs to take to prevent self-injury in that kind of situation?
The very first, most crucial practical step, prepare the environment. Make it safe.
How so?
When someone's that agitated, having hallucinations, their reality is warped. Their actions are unpredictable. So it means meticulously removing anything they could use to harm themselves. Anything. Sharp objects, cords, belts, you name it.
Really clearing the space.
You're basically creating a physically safe bubble around them, protecting them from themselves in that moment.
That's a stark reminder of the immediate dangers. Okay, moving on to suicidal ideation and self-harm protocols.
Yeah.
Let's take an adolescent who attempted suicide with an acetaminophen overdose. An empty 30-tablet bottle was found.
Okay. Very serious.
Given that specific overdose, what is the critical immediate action for the nurse? Why is it so uniquely essential?
Acetaminophen overdose. The one treatment that stands above all others, the truly time-critical one, is giving acetylcysteine immediately.
Acetylcysteine, why specifically? You mentioned hepatic insult before, liver damage.
Exactly. Acetylcysteine works by replenishing glutathione. That's something the liver absolutely needs to detoxify the really toxic byproduct of acetaminophen before it causes irreversible liver cell damage.
Ah, I see.
It's literally a race against time to protect the liver. So getting that acetylcysteine in immediately is paramount.
A crucial biochemical point.
Okay.
Now, picture a client coming into the ER after a panic attack, obviously a deeply unsettling experience.
Yeah, me too.
When the nurse is assessing them, there are tons of questions you could ask. But what's the single most important one initially, especially in that crisis context?
In any crisis, really, but especially after an acute panic attack where emotions are raw, judgment might be off. The most important question, unequivocally for client safety, is, have you had any thoughts of hurting yourself?
Straight to the point.
Absolutely. Assessing for suicidal ideation isn't just good practice. It's a fundamental priority. It underpins everything else you do, sets that safety baseline.
That idea of foundational safety. It's not just clinical actions, is it? It's also about our responsibilities, ethically and legally. Which leads us nicely into some of the trickiest decisions nurses face, especially when safety for the client, or maybe others, is on the line. Let's talk about the duty to warn, the Tarasoff decision.
Right, a landmark case.
So if a male client tells the nurse during a session, I plan to kill my spouse and her lover as soon as I get out of here, what does the nurse have to do? Why does this demand breaching confidentiality?
This is a direct textbook application of Tarasoff. The core principle is clear. The duty to protect an identifiable third party from a clear and present danger overrides client confidentiality.
So confidentiality is an absolute.
Not when there's a specific credible threat to a specific person. So the crucial action isn't just documenting it, it's filing reports oral and written with the local police.
Police involved immediately.
Yes. And the healthcare provider needs to be notified instantly too, and the whole plan, the threat, the actions taken, meticulously documented in the client's record. It's about doing everything possible to prevent a foreseeable tragedy.
That's a heavy responsibility. Balancing confidentiality and public safety. Okay, connecting that to another legal aspect. Involuntary commitment criteria.
Right. When can someone be held against their will for evaluation?
Exactly. Let's say a male client is brought to the ER by police. The officer says he was disturbing the peace, running naked in the street, striking out at people, smashing car windows.
Wow, okay.
Among those behaviors, which ones specifically trigger an evaluation for involuntary commitment?
Well, if you look at the big picture for involuntary commitment, the criteria usually boil down to likelihood of harm to self, likelihood of harm to others, or being gravely disabled, unable to provide for basic needs.
Okay.
In this case, the behaviors that scream evaluate now are the striking out at others, that's a direct threat, the disruptive behavior in a community setting, and especially smashing car windows, the property damage.
Why the property damage specifically?
Because it shows a significant lack of control and potential danger. These aren't minor things. They strongly indicate a present danger to others, or possibly a severe inability to care for himself, justifying that hold for evaluation.
Clear indicators of a direct threat, then.
Okay.
Let's shift gears a bit. Let's talk about understanding psychotic disorders and maybe the power of therapeutic communication, especially in groups.
Group therapy dynamics can be fascinating.
Right. Imagine this. In group therapy, one client shares, clearly distressed, I hear voices saying, my doctor will poison me.
Okay, a delusion or hallucination.
Then another client responds with empathy. You know, I used to hear voices too. I found out they were just my imagination. The voices you hear aren't real either.
Ah, interesting response.
What's happening there? What's that phenomenon called and why is it so valuable?
That's a fantastic example of reality testing in action within a group setting.
Reality testing.
Yeah. What's powerful is how the group dynamic itself fosters it. Members give each other feedback, kind of check perceptions, monitor reactions, all in a non-threatening way.
Peer feedback.
Exactly. In your example, the second client isn't just dismissing the first client's fear. They're sharing a relatable past experience and then gently, but clearly, helping the first client check their perception against shared reality. Mine weren't real, yours probably aren't either. It's a way for people to collaboratively figure out what's real and what might be a symptom within a supportive space.
That peer element sounds incredibly powerful. Now, thinking about priorities in managing schizophrenia. Say you have a client with catatonic schizophrenia. They're mute, motionless, almost like a statue.
Deeply withdrawn state.
What's the immediate priority nursing problem? It feels like there could be several issues.
There could be, but when someone is in a catatonic state like that, while the psychiatric symptoms are obvious, maintaining physiological stability becomes the absolute top priority.
Body first.
Yes. Their immobility puts their basic physical needs at huge risk. So the number one nursing problem is high risk for fluid and electrolyte imbalance. Think malnutrition, dehydration. These are immediate threats.
More immediate than the psychiatric state itself.
In that moment, yes. The other challenges are important, of course, but they aren't as immediately life-threatening as severe dehydration or electrolyte issues. You have to address the life-threatening physical stuff first, always.
Physiological stability first. Okay, what about managing agitation and vital signs? You have a client with schizophrenia, has been taking meds, extremely irritable, pacing constantly. Their blood pressure is up 146/96.
Okay, agitated and hypertensive.
What's the priority nursing action? My first thought is, I need to address that BP.
And that's a really common, understandable first thought. But this scenario makes us question how we interpret vital signs, especially with a new admission or someone under acute stress.
Context matters.
Hugely. The client is irritable, pacing.
Yeah.
That alone can temporarily spike blood pressure significantly. The excitement, the anxiety, just the stress of being admitted.
Right.
So the actual priority nursing action here isn't to jump to medication immediately, but to reevaluate the client's blood pressure in an hour. Give them time for that initial stress and agitation to maybe settle a bit.
Before intervening for what might just be a temporary spike.
Exactly. Avoids potentially unnecessary intervention for something that might resolve on its own once things calm down a little.
That makes perfect sense. Context is everything. Okay, last one in this section. Self-awareness in nursing. So important for connection.
Crucial.
A nurse is talking with a male client who's describing the deep sadness he felt when his mother died. The nurse starts thinking about her own grandmother's death.
Relating internally.
And then asks the client, can you describe your thoughts when you first learned about your mother's illness? What's a nurse doing there, therapeutically speaking, and why is it effective?
This is a beautiful, subtle example of self-awareness being used therapeutically.
Self-awareness.
Yes. The nurse is aware of her own feelings, her own experiences with loss. But instead of letting that get in the way or making it about her, she uses that internal resonance to deepen her empathy for the client.
How does asking the question help?
By gently reflecting on her own experience, even just internally, she connects with his potential feelings, asking him to describe his thoughts when he learned of the illness. It comes from that place of understanding. It creates an opening, signals empathy. It makes the client feel understood, safer, perhaps more willing to open up about his own experience.
Using her own humanity to connect.
Precisely. It fosters a more authentic, therapeutic interaction.
That's powerful stuff. Okay, let's transition now to some broader patient care scenarios. We'll touch on compassion, careful assessment, coping strategies. First, supporting grieving parents. An incredibly tough one. Parents experience a fetal demise, a stillbirth, and they express a strong wish not to see the baby.
Heartbreaking.
What should the nurse do, especially considering the long-term impact of such a loss?
This is just incredibly sensitive. And while, yes, best practice often encourages parents to see and hold their infant after death, it can help with closure, with grieving.
But they don't want to.
Their wishes absolutely must be respected above all else. So the immediate intervention is respect their wish, release the body to the morgue as requested.
Okay.
However, there's a crucial layer of compassionate flexibility here. It's also really important to keep the body available for a few hours.
What's that?
Because intense grief, shock, it can lead to immediate decisions that people might later regret. This subtle act acknowledges that. It offers them a small window, a chance if that initial shock wears off and they perhaps change their minds. It's foresight, rooted in compassion.
That's incredibly thoughtful. Okay, next, identifying and addressing domestic violence. A female client comes in with facial bruising.
Okay, red flag.
When assessing for possible domestic violence, what's the single most therapeutic assessment question the nurse can use? Why is the wording so important?
When you suspect domestic violence, you have to remember the victim might be feeling fear, shame, maybe even blaming themselves. Direct accusatory questions often shut communication down.
Right.
So the most therapeutic question is deliberately non-judgmental and open-ended. How did this happen to you?
Simple, but powerful.
Yes. The wording is vital because it creates a safe space. It doesn't interrogate, it doesn't judge, it doesn't corner them. It simply invites them to share their story if they feel ready, on their terms.
Invites disclosure, doesn't force it.
Yeah.
Okay. And staying on domestic violence, let's say a nurse is doing general women's health teaching with a female client who happens to be in a homosexual relationship. What topic is the most important for the nurse to address, maybe even regardless of other health issues?
This is often overlooked, but it's critical. The most important topic remains domestic violence interventions.
Even in a same-sex relationship?
Absolutely. The key insight here is that domestic violence is a universal risk. It cuts across all demographics. All women, regardless of sexual orientation, socioeconomic status, relationship type, are potentially at risk for serious, even lethal, domestic violence.
So it's a universal screening point.
It has to be. While other health topics are important, sure, domestic violence is a potential life or death issue that needs to be on the radar for all female clients.
A crucial reminder. Risk doesn't discriminate. Okay, now a client presents to the emergency center. They've been raped. They're showing signs of acute rape trauma syndrome, confusion, emotional numbness, disbelief.
A state of shock.
What is the very first action the nurse should implement before even diving deep into assessment?
In that acute phase, with the shock, numbness, disbelief, the client is often completely overwhelmed, disoriented.
Understandably.
So the absolute first action isn't starting invasive procedures or firing off complex questions. It's actually to explain the rape protocol.
Just explain what's going to happen.
Yes. It sounds simple, but it's vital. It prepares the client for what's coming on, the forensic examination, the legal process involved. It helps minimize additional trauma or shock during the evidence collection and assessment. It gives them a sort of roadmap, even if it's a terribly difficult one. Transparency first.
That makes sense, giving some structure and chaos. Okay, let's talk about managing client disappointment and anger. Another common challenge.
Definitely.
A male client is on the liver transplant list. He gets devastating news. The potential organ donor is no longer available.
Crushing news.
He reacts with intense anger, slamming doors, shouting vulgarities. How should the nurse respond? What's the most effective action right then to de-escalate and support him?
When you're faced with that kind of raw, intense emotion, the most effective therapeutic action is to encourage him to share his feelings more appropriately.
Not shut him down.
No, definitely not shut him down. It's about channeling the emotion constructively. It means providing a non-judgmental, supportive, safe space where he can express the profound disappointment, the frustration, the anger, but without escalating things to the point of harm to himself, others, or property.
Create a safe outlet.
Exactly. An outlet, not suppression. Acknowledge the feeling, guide the expression.
Okay. Allowing expression, but safely. Now, recognizing signs of mania versus depression. For a client with bipolar disorder, which kind of statement is most typical of mania? What does it reveal about their mindset?
A statement really typical of mania might sound something like this. I manage our finances great because I buy in big quantities.
The great deal mentality.
Exactly. It immediately shows that characteristic inflated self-esteem, the grandiosity, and the action itself, buying in big quantities, points to the excessive spending, the impulsivity, poor financial judgment, all hallmarks of a manic episode. It reveals that distorted sense of capability and risk assessment.
Really highlights the grandiosity and impulsivity.
Okay. And flipping to depression. A client has a diagnosis of major depression, single episode. Which lab value is most important for the nurse to report immediately to the provider? And why is this lab so critical in a mental health context?
This connects back to looking for underlying physical causes. An increased thyroid-stimulating hormone level, TSH level, is the most important one to report immediately.
TSH.
Why? Because an elevated TSH strongly suggests hypothyroidism and underactive thyroid.
And that matters for depression
Because hypothyroidism can present with symptoms that look almost identical to major depression. Fatigue, low mood, lack of energy, cognitive slowing.
It mimics depression.
It can, very closely. So it needs immediate attention because it's a treatable physical condition that could be directly causing, or at the very least, significantly worsening their depressive symptoms.
Yeah.
You have to rule out or treat the physical causes. Critical connection, okay? Nearly there. Assessing coping mechanisms. A young adult female, known panic disorder, comes in with chest pain after her boyfriend left her. Big stressor.
Would be your life stressor, yeah. Chest pain with panic history. Needs careful assessment.
Beyond just her emotional state, what's the most important information the nurse needs to get?
Given her symptoms, the panic history, the intense stressor, the most crucial information to obtain is a history of drugs taken in the last 7 days.
Drugs, meaning?
Meaning everything. Prescribed meds, over-the-counter drugs, vitamins, herbals, and especially any illicit substances.
Why is that so critical here?
Because substance use or even withdrawal from certain substances can significantly influence behavior, physiological responses like chest pain or palpitations, and definitely the ability to cope with stress. It can mimic or worsen anxiety and panic. You need that full picture for safe and effective care planning.
Drugs can really muddy the waters. Okay, and speaking of coping, A client with depression cries when just trying to make menu selections for meals.
Wow, even simple decisions feel overwhelming.
Exactly. Which type of therapy group would likely be most beneficial for this client, and why that one specifically?
That behavior, crying over menu choices, is such a vivid illustration of a core issue in depression. Ineffective coping. They're struggling with basic decision-making, emotional regulation.
Just overwhelmed.
Totally. Therefore, a therapy group that specifically focuses on coping skills is likely to be the most beneficial.
Directly addressing the problem.
Exactly. It directly targets that fundamental deficit. It aims to equip them with practical tools and strategies to manage daily stressors, regulate emotions, and handle decision-making more effectively. Building those skills is key.
What an incredible journey through these scenarios today. We've really had a deep dive, haven't we?
We certainly have.
From those acute mental health crises right through to broader patient care situations. And I really hope, listening to this, you can see how getting underneath the what to understand the why.
The rationale.
Yet the rationale behind interventions, behind assessments, how that could be a genuine shortcut to being truly well-informed when facing critical healthcare decisions.
Yeah.
It's about getting beyond just memorizing facts.
It really is. These insights don't just give you knowledge, they sharpen your critical thinking. They allow you, hopefully, to see the nuances, the layers in patient care.
To see the pattern.
And prioritize effectively when things are moving fast, understanding the core reason for every key action.
So as you reflect on all this, maybe think about this. The profound human element that runs through every single clinical decision we talked about.
Even the most technical ones.
Right. Even when the most urgent action seems purely medical or procedural. Consider how empathy, compassion, just a deep understanding of the individual, how that always underpins every truly successful intervention. How it fosters that crucial trust, especially in those incredibly vulnerable moments.
It's not just about what we do.
It's how we are with our patients. That often makes all the difference. Something to think about.